Ladies and gentlemen, good afternoon. Thank you for joining the professional talk of Hong Kong Parkinsons Disease Foundation. 各位午安啦，歡迎大家去參與呢個香港柏金遜症基金嘅講座啦。咁提一提大家啦，如果呢個講座係用英文啦。各位午安啦，歡迎大家。係啦，咁呢個 talk 咧，我哋係會用英文進行，咁但係咧，亦都會有中文嘅即時傳譯啦。咁如果大家咧係需要選擇去聽中文咧，咁就可以咧喺嗰個Zoom 入邊，我哋嗰個菜單咧係有一個叫口譯嘅掣啦，一個口譯嘅掣，選擇簡體中文啦，選擇簡體中文啦。咁如果係跟住可以再選擇將原始嘅音訊靜音啦，咁咧就會係完全聽到翻譯員嘅中文嘅講解啦。咁如果咧係用呢個手機啦，或者係平板電腦嗰啲啦，咁就可以睇下嗰個菜單下邊咧有個3點嘅標誌啦，咁嗰個標誌下邊亦都會有語言嘅選擇啦，語言嘅選擇，咁咧選擇簡體中文啦。跟住咧就將個原始嘅音訊你可以靜音啦，咁係完成啦，咁基本上咧就可以聽到中文嘅翻譯。咁如果係聽英文嘅咧，係唔需要去撳呢個翻譯嘅掣嘅嚇。For ladies and gentlemen, for those who are planning to listen English for this talk, you don't need to press the translation button. You just listen the original channel that will do. Thank you.
Thank you very much, Oscar. Welcome all of you, ladies and gentlemen. I'm Professor S.L. Ho, the chairperson of the Hong Kong Parkinsons Disease Foundation and the moderator for this webinar. This webinar is part of our 20th anniversary celebration of our formation of our foundation. One of the mission that we have is to provide educational programs to healthcare workers and carers of Parkinson's disease patients to improve their care. And this webinar is part of that mission. I would like to thank the sponsor, Lundbeck, for supporting this webinar. I also would like to thank the interpreters, Dr. S.H. Young and Dr. Lorenda Kwan Ching, for providing the Chinese simultaneous interpretation service. More importantly, I'd like to thank Dr. Siddharth for delivering a lecture entitled Updates of COVID infection and the risk versus benefits of vaccination, complications in neurological disorder, including Parkinson's disease. Dr. Siddharth is one of our up-and-coming academic clinicians. He is a clinical assistant professor at the Department of Microbiology of the University of Hong Kong. He is a clinical virologist with a special interest in emerging infectious diseases and the impact on vulnerable patient groups. He is actively involved in COVID research and has published several studies on COVID-19 diagnostic assay development, seroepidemiological studies, animal models, clinical pathological research, and surgical mask efficacy. He is also keenly involved in community engagement on COVID-19 via both social media and traditional media. I would just like to allow a slight delay of about 10-20 seconds to allow the change of the interpreters before Dr. Siddharth gives his talk. So the floor is yours, Dr. Siddharth.
Right. I do hope everybody can see my screen now. I would like to thank Professor Ho for the very kind introduction and invitation to this very meaningful program. And I'm going to share my thoughts on COVID-19 vaccination, as well as provide a broader picture of what COVID-19 infection looks like in Hong Kong at the moment. I'm going to try to focus on individuals, patients with Parkinson's disease, as well as other neurological disorders, as much as possible throughout this talk. And I want to keep my words as short as possible, and I hope we can set aside more time for the Q&A session and have a very fruitful discussion at the end of the talk as well. So let's begin. As we all know, COVID-19 is caused by a virus, and the virus is called SARS-CoV-2, SARS coronavirus 2. So it's the second version of the SARS virus that affected Hong Kong so badly in 2003. The SARS-CoV-2 is basically looks like this. Viruses are very small particles, but if you look at this picture of the virus, you will notice that there are a lot of projections from its surface. So there seem to be dots all around the virus. And a cartoon of the virus is here, and you can see that the dots are basically proteins that are sticking out of the virus surface. And this protein is called the spike protein. So I'm sure many of us would have heard about the spike protein, and it's very important for the purpose of this talk, because the spike protein is a very important target that our body recognizes to produce antibodies. And these antibodies help to protect us against COVID-19. So if you want to remember something about the structure of the COVID-19 virus, the spike protein is a very important one. COVID-19 has caused tremendous problems throughout the world, tremendous suffering, disruption across the entire world in the last 2 years and 3 months now. The WHO data indicates that there are 437 million confirmed cases, but this is likely to be a significant underestimate. There are likely to be many, many more cases than that. Including this, there are nearly 6 million deaths due to COVID-19 recorded worldwide. 6 million. So that's a huge number. But again, the real number is probably closer to 10 million, because we don't have the capacity for recording every single death due to COVID-19. The good news is that the best way we have of controlling COVID-19, which is vaccination, is very widely used as well. So you can see that there are 10 billion vaccine doses have been deployed worldwide. And this is absolutely amazing and has already saved hundreds and thousands, if not millions of lives across the world. Now, the first thing, although we are focusing on neurological disorders for this talk, we must understand that COVID-19 is basically a respiratory virus. Basically, it affects the respiratory tract going from the nose down to the lungs. Most infections, particularly in younger patients, tend to be confined to the upper respiratory tract. So they have sore throat, runny nose, bit of cough. This is upper respiratory tract symptoms. But lower respiratory tract infections are common, especially in those with elderly or those with chronic medical conditions. Old age, male sex, high blood pressure, diabetes, obesity, chronic medical conditions, and immunosuppressive conditions are all factors that predispose to this picture of COVID-19 affecting the lungs, which is a serious condition. So in terms of patients with neurological disorders, this is a complicated table, but I'll try to break down these tables into something that makes sense. So this is a study that is looking at people with underlying medical conditions. And this is a very large study in the United Kingdom, which found in a large number of COVID-19 patients, nearly 8,000, which is 12%, had underlying neurological disorders. And a lot of these patients also had complications. Okay, a lot of these patients also had complications. And these complications involved many different organ systems. And most commonly, they suffered from neurological complications. So although this is a respiratory virus, people do tend to have unfortunate things, complications affecting their neurological system. And I'll explain what that actually means in subsequent slides. If we look at the death rates, unfortunately, individuals with any kind of underlying chronic medical conditions are at a higher risk of dying of COVID-19. So if you look at patients with neurological disorders, their risk of death is higher. So the more it is towards this side, the higher the risk of death compared to a healthy person. So patients with neurological disorders do have a 1.2 higher risk of death and a 1.8 higher risk of ICU admission, so admission to critical care. So patients with neurological disorders do tend to have more difficulties if they're COVID-19 infected. Why does this happen? So why do people with neurological disorders not only have a higher risk of severe COVID-19, but also more neurological complications? This graph shows why that might happen. Essentially, when we get infections, any kinds of infections, for example, influenza, a small proportion of individuals may develop neurological complications during the infection due to a condition called encephalitis or encephalopathy. So when there is some kind of a brain involvement, it's not that the virus directly invades the brain, but what can happen is that our body can react to the virus in a way, high fever, large amounts of inflammation that can affect brain function. Okay, and that can happen during the infection per se. Once the infection gets better, there are still neurological complications that can occur. And these are post-infectious or vascular complications, which I'll talk about in a subsequent slide. What about Parkinson's disease? Actually, studies on Parkinson's disease and COVID-19 are relatively few, and the quality is not that great. This is one study that looked at a collection of studies looking at the death rates due to Parkinson's disease and found that the odds ratio of death were about 1.4 times that of individuals without Parkinson's disease. So it seemed slightly higher. However, a more exhaustive study published in the British Medical Journal found that individuals with Parkinson's disease specifically were at significantly higher risk of dying of COVID-19. So again, going back to the same point, chronic neurological conditions and Parkinson's disease in particular are related to more severe COVID-19 risk. There's no doubt about that. What about the effect of COVID-19 on Parkinson's disease? Does COVID-19 make Parkinson's disease symptoms worse? This small study indicates that this indeed is the case. In this Italian study, they found that patients with Parkinson's disease who contracted COVID-19 did have clinical deterioration, and this mostly affected both motor symptoms, but it also did affect some non-motor symptoms. So the motor symptoms are obviously in terms of worsening tremors, worsening gait instability. Non-motor symptoms included urinary issues and fatigue. So this happened in Parkinson's disease patients with COVID-19. Luckily, in many of these patients, this temporary problem deterioration improved gradually. But in many patients, it was a significant disruption to their normal level of functioning. Yeah. Now, this is a very important slide. Deterioration of Parkinson's disease is important, but we must also remember that many patients with Parkinson's disease are older They may have hypertension or diabetes or other cardiovascular risk factors. This means that they're at a higher risk of stroke or heart disease. Now, a very important study this year found that individuals with COVID-19 are at higher risk of stroke and heart disease for up to 1 year after the infection. Generally, the more severe the infection is, marked in red or blue here, the risk of developing cardiovascular disorders, stroke or heart disease in the 1 year after COVID-19 is much higher than in those with a mild infection. So that is very relevant to the elderly community in general and the Parkinson's disease community in specifically. In summary, neurological complications of COVID can occur both acutely and during recovery. If you have underlying neurological disorders, including Parkinson's disease, there's a higher risk of severe COVID-19 and COVID-19 related death. After COVID-19, the most important neurological complication is stroke. There is an increased stroke risk in the 1 year after contracting COVID-19. So this is kind of the background of COVID-19 and neurological disorders. Why we're all sitting here today listening to this talk is because of Omicron, right? This is the variant that has taken over the world and in many ways has made life very difficult when it comes to COVID-19 in Hong Kong in particular. Omicron is a variant of concern. What that means is it's something that has rapidly spread globally and is also something that has replaced previous variants. So you can see the initial experience in South Africa was that Omicron emerged in November and very quickly replaced older variant like Delta. And this is the experience throughout the world. Omicron spread like wildfire and replaced previous variants like Delta. A particular subvariant of Omicron called BA.2 accounts for most cases in Hong Kong. Okay, so it's Omicron that is causing all the problems in Hong Kong at the moment. The funny thing about Omicron is that it is even more infectious than previous variants. It is a very, very infectious virus indeed. And no matter what subvariant of Omicron you're talking about, as long as it's Omicron, it's very infectious. In this Dutch study, they found that if a person with COVID-19 has, if for every house in which there is a person with COVID-19, up to 40% of all the people in the same household are going to get infected. In Hong Kong houses that are much smaller, honestly, this goes up to nearly 100%. It's very difficult to avoid infections. The same study conclusion was found in the UK, which found that secondary attack rates in the household where they have bigger houses is pretty high when it comes to Omicron compared to previous variants, especially the BA.2, which is even more infectious. But again, when you talk about the Hong Kong setting with smaller houses, household transmission is almost unavoidable. The good news about Omicron for most parts of the world is that it is less severe. We do know that Omicron has caused less death compared to previous variants like Delta in both South Africa and the UK. But the reason is very important to understand. Omicron is less severe than Delta, it's true. However, these countries, for example, South Africa, have a very high rate of past infection due to other variants. So the entire population has some degree of immunity. In the UK, more than 90% of elderly are vaccinated or even boosted against COVID-19. So they have a strong level of personal immunity. However, in Hong Kong, those conditions do not exist. No one had contracted COVID-19 previously, and the vaccination rate in the elderly, which I'll talk about a lot in the coming slides, is relatively low. So Omicron in Hong Kong still causes a lot of severe disease because it infects so many people and because vaccination rates and prior infection rates in the population are very low. So it's less severe, but because it causes more disease, more infections, you still see a lot of severe disease. And that's been our experience with Omicron in Hong Kong. We've all seen the pictures. It's caused tremendous disruption. The Hong Kong Omicron wave is one of the most severe COVID-19 waves since the start of the pandemic. Globally in 2022, definitely Hong Kong is the most severely infected place in the world by COVID-19. And I'm talking about at any point of the pandemic. In the last 2 years, we have rarely seen a wave that is as devastating as the COVID-19 wave in Omicron in Hong Kong right now. The figures tell all the stories. Everywhere in the world, we're seeing Omicron. There's no doubt about it. This is a comparison of Hong Kong and New Zealand. You can see that both have experienced tremendous spikes due to Omicron. And this is in terms of cases per million population. You can see that they're almost neck and neck. However, when you look at the deaths, it's a completely different story. In Hong Kong, the deaths per million due to Omicron is much higher than New Zealand, which is almost a flat line, almost unaffected. So why does the same variant cause such different disease in two different places? The simple answer is vaccinations. So Hong Kong's COVID death rate is one of the world's highest for a high-income region. We're #1, unfortunately, in terms of death rate, and that's because of the vaccination rate. If you look at the elderly segment of the population in Hong Kong, 60 and above, you will see that there are a lot of people who have decided not to get vaccinated. We're talking about nearly 500,000 individuals who are elderly who have not gotten vaccinated. And this has killed us during the current community epidemic. So this graph tells the same story. You look at vaccination rates in different segments of the population. You can see that for the entire population, the vaccination rate overall, 1 dose or above, is not bad. We are nearly at 80, actually we're more than reaching 90% almost, so it's excellent. But the problem is the people who should have gotten vaccinated haven't. If you look at the 60 and above population, especially the 70 and above population, less than half are actually vaccinated with even 1 dose of a COVID-19 vaccine. And this is the fundamental difference between Hong Kong and other parts of the world that prioritized elderly vaccination rather than vaccinating younger individuals who are less at risk of dying of COVID-19. Okay, so things work the other way around in Hong Kong, and that's caused a lot of the problem. The statistics tell the story in an analysis of the first 3,000 odd deaths due to COVID-19 in the 5th wave. Nearly 90% had not received 2 doses of the vaccine. So this tells the whole story. Broken down by age, if you're 80 and above and catch COVID-19, the risk of dying is 12%. That's very high indeed for an infection. But if you get the vaccine, that 2 doses of the vaccine, that shrinks to 3%. And the same applies to younger age groups, 70 to 79 and 60 to 69. If you receive 2 doses of the vaccine, the risk of dying is dramatically lower. So this is a very, very important point. Vaccines do not prevent catching the infection, but they do prevent severe disease. So we have 2 vaccines available in Hong Kong, as we all know. One of them is the CoronaVac vaccine, which is an inactivated vaccine. The other vaccine is the mRNA vaccine, which is the BNT162b2 or Comirnaty. So we have 2 vaccine types available in Hong Kong. How effective are these? How do they work? Inactivated vaccine, which is the CoronaVac vaccine, is very easy to understand. It's basically a virus that is grown in a laboratory and is basically killed in some way. It's inactivated. It's a killed virus. And we literally just inject the killed virus into our body to excite an immune response. Because it's a killed virus, the vaccine would not cause any disease in the body. So that's basically how the inactivated vaccine works. In terms of the BioNTech vaccine, which is a newer vaccine technology that people are very worried about, basically what it is it's part of the COVID-19's genetic code. Think of it as the COVID-19 gene that encodes the spike protein that I was talking about in my very first slide. Once it's injected into the body, it causes the immune system to produce antibodies against the spike protein. So if the patient catches COVID-19, they have a great amount of antibodies and other protective mechanisms directed against the spike of the virus that keeps them safe from severe disease. Point to note is that mRNA vaccines do not change our DNA. They do not persist in the body for prolonged periods of time. And even the spike protein that is expressed is just part of the virus that is quickly cleared from the body. So they're very unlikely to cause any long-term side effects. In terms of their performance against Omicron, we have a lot of data for the BioNTech vaccine. You can see this is data from the United Kingdom. Generally speaking, if you receive 2 doses of the BioNTech vaccine, the protection against catching Omicron infections goes down quite a lot over time. But if you get a 3rd dose, the protection shoots up to 60 to 70%. But it also does decline over time. But actually, this is not important. Protection against catching COVID-19 or symptomatic infection is nice, but it's not essential. It's much more important to protect against severe disease, right? And that's what the vaccines do so well. If this is protection against more severe forms of disease from the UK, so you'll find that basically 2 doses of COVID vaccines are okay. They do have a fair degree of protection against severe forms of Omicron. But if you get the 3rd dose, that protection shoots up to 80 to 90%. That's exactly what we're seeing in Hong Kong. If you get 2 doses and above of COVID-19 vaccines, the chance of dying or critical disease is much lower. So what about CoronaVac, which is the other vaccine available in Hong Kong? Now, data effectiveness against Omicron for the CoronaVac vaccine, we're still waiting for. But the good news is that we do have a lot of antibody data that has been produced by researchers in Hong Kong. So what they generally find is that just like BioNTech, if you get 2 doses of CoronaVac, you have not a lot of antibodies against Omicron. If you get 3 doses of CoronaVac, it doesn't improve too much. But if you have received 2 doses of CoronaVac in the past, if you get a shot of BioNTech on top, so that's 2 doses of CoronaVac first and then BioNTech, the antibody levels shoot up to a very nice level. And that would be expected to protect you to a certain extent from infection and to a large extent against death. So which is why the official recommendation in Hong Kong is that if you receive 2 doses of CoronaVac, get BioNTech as your 3rd dose. So that's the official recommendation. Great. So now let's go over why that is the case. So you might be asking me, if antibody levels go down, how do the vaccines protect us against severe disease? Well, the reason they do this is apart from antibodies, there are also T cells in our body. T cells are amazing cells that enable us to fight against more severe forms of the disease, okay? And whether you get the BioNTech or the CoronaVac shot, this is data after 2 doses, you're still going to generate a lot of this good T cell immunity that is so important to fight severe infections. So generally speaking, protection against catching COVID from vaccines is not that great. It goes down over time, but protection against catching severe disease, so catching an infection and then going on to develop severe disease or dying, the risk is much lower after getting COVID-19 vaccines compared to an unvaccinated individual. And this is the most important point I want to make in this presentation. But let's shift back a little bit to Parkinson's disease. Generally speaking, individuals with Parkinson's disease are strongly recommended to get the COVID-19 vaccine. But a lot of you may be concerned, how do the vaccines impact my symptoms due to Parkinson's disease? Not a lot of data again, but what I have found is this Italian study again that looked at 177 individuals with Parkinson's disease who received the BioNTech vaccine. After receiving the BioNTech vaccine, 1.1%, that is 2 patients, experienced slightly increased rigidity and tremor, which quickly improved. Remember, at any one point, as Professor Ho will tell you later, it is always possible for Parkinson's disease patients to develop temporary changes in their symptoms. So because the study did not have a control group that was unvaccinated, we cannot definitely link the deterioration in symptoms to the vaccine. And it's most important to know that it was transient and it quickly improved. There is no doubt that patients with Parkinson's disease can safely take the BioNTech vaccine. And given how bad COVID-19 is in this population, the risk-benefit analysis is very clear, okay? The vaccine will save your life. Even if it's linked to a small deterioration of symptoms, this is temporary and improves spontaneously according to this study. What about CoronaVac? So for Parkinson's disease, there's no specific data, but it is generally presumed safe. If you look at the product insert for CoronaVac, they do mention severe neurological conditions. But my understanding, severe neurological conditions cannot receive CoronaVac. But the understanding is that this refers more to autoimmune diseases like Guillain-Barré, transverse myelitis, or demyelinating diseases. It may not specifically refer to Parkinson's disease, which is not an autoimmune process. We do not reasonably expect that CoronaVac will cause deterioration in Parkinson's disease symptoms. This should not be the case. So I would presume that it is safe in Parkinson's disease, even if we are lacking some of the detailed pharmacovigilance data that we would like. But the same story. Think about COVID-19 in a Parkinson's disease patient, how severe it gets. I think the vaccines are absolutely safe in this population. Now, if you follow the news in Hong Kong, every day the news articles would report somebody dying after vaccination, and that scares a lot of people, right? But it's very important to look at the big picture, okay? And this is the big picture. We do very, very high quality safety monitoring of COVID-19 vaccines in Hong Kong. And this is the latest update of the report in January 2022. Ever since we started vaccinating people in Hong Kong, we have administered, as of 31st January, we've administered 11 million doses. Out of these, there were 64 reports of deaths occurring within 14 days of vaccination. 64. This accounts for 0.0006% of all vaccine doses administered. 0.0006% was the number of cases per 100,000 doses administered. So it's a very, very low rate, okay? 40 of the deaths were after CoronaVac. 24 of these deaths were after BioNTech. This is not surprising because in Hong Kong, CoronaVac recipients tend to be older, so the baseline risk of dying is a bit higher. Most importantly, trust me, each of these cases is exhaustively investigated. There was never a link identified between deaths and vaccines. We have to understand that at any one point, there is always a risk that elderly individuals with chronic medical conditions might die. There is a baseline risk, but there is no evidence that vaccines increase this baseline risk. And this is the point that I'm trying to convey. Look at this. In 1 month in January 2022, this is a record of the deaths in public hospital. The death rate in cases with the vaccine record was lower than a death rate in cases without a vaccine record, without an inoculation record. So this clearly proves that deaths do not increase the death rate. Vaccines do not increase the death rate compared to the unvaccinated population. Look at the data from the United States, the same story. They looked at the BioNTech vaccine, which is what they have there, and they compared it to an unvaccinated comparison group. Irrespective of the age group studied, the death rate in those who received vaccines was never higher than in those who did not receive vaccines. They removed COVID-19 related deaths here. Even so, death rates due to the BioNTech vaccine were no higher than in those who do not receive the BioNTech vaccine or who remain unvaccinated. So please understand that on a statistical basis, there is absolutely no evidence that COVID-19 vaccines increase the death rate. And I really hope that our local media can appreciate this point instead of spreading fear about COVID-19 vaccines. We've also done great studies at the Department of Pharmacology and Pharmacy in the School of Biomedical Sciences of the University of Hong Kong. They looked at patients with chronic medical conditions, multi-morbidity, and they looked at adverse events, not just death, other kinds of things like heart attacks, strokes, blood clots, a long list of adverse events. There is no evidence that chronic medical conditions imposes extra risk of adverse events following COVID-19 vaccines, a categorical conclusion. It's a bit complicated, the analysis, but I'm going to show you a little bit of the data to show you why this is so striking. Okay, so please look at the upper graph. These are unvaccinated individuals, okay? So this is their cumulative risk of having an adverse effect, which means a poor health outcome within 1 month. So any unvaccinated individual, if you follow them up for a 28-day, any individual on the street, you follow them up for 1 month, there is a small baseline risk of something bad happening. That's what this graph happens. Unavoidable, that's life. There is always a risk. In those who have comorbidities, hypertension, diabetes, the red line, you will see that the risk is obviously higher than in those without comorbidities. Obvious, right? If you have hypertension, diabetes, the baseline risk of something bad happening like a stroke or a heart attack or death is higher than a healthy individual. That's common sense. This basic relationship is not altered with vaccination. It's not altered irrespective of whether you receive mRNA vaccines or the CoronaVac, BioNTech or CoronaVac. In fact, the risk of having these adverse events is not increased even in individuals with chronic medical conditions compared to the baseline risk that these individuals face if they were unvaccinated. So again, if you have well-controlled chronic medical condition, vaccination is the obvious choice. There is no increase in baseline risk compared to the population. Again, I wish our media would look at the big picture and understand that unfortunate events always happen in life, but just because something happens after a vaccine does not mean that it is related to the vaccine. The risk of bad things happening after a vaccine is no higher than if the person were unvaccinated. And we do have very robust mechanisms for tracking these things in Hong Kong. So have faith in the system. It's been screaming the truth at us for the last 1 year. We have not heeded it, and Hong Kong is in a very bad position today. So an earnest appeal. If you're not vaccinated, if you're elderly with chronic medical vaccinations, the data supports vaccination. A lot of the audience would be worried about heart attacks and stroke. There is extremely high quality data from Europe and Israel on a population-wide scale that there is no evidence that the BioNTech vaccine used in those areas is associated with increased risk of stroke, heart attacks, or blood clots. No evidence whatsoever. In multiple high-quality pharmacovigilance studies, we're still waiting for that kind of pharmacovigilance data for CoronaVac on a nationwide scale overseas, but the data that we have in Hong Kong suggests the same. There is no increased risk of adverse events of special interest after receiving the COVID-19 vaccine. So same story. Okay, now all of you would have heard about this. This is due to COVID-19 vaccines. This is due to mRNA vaccines that BioNTech in particular. Myocarditis is proven to be due to the BioNTech vaccine, and it is the fabulous pharmacovigilance systems, first in Israel, that actually picked up the side effects. So it builds faith in the system that we're detecting these signals on a population-wide basis and the system is working. you would see that the BioNTech vaccine clearly increases the risk of myocarditis in males, especially after the second dose of the vaccine, within a few days. This is beyond doubt. It sounds very serious, inflammation of the heart, but luckily most of the cases of myocarditis are still mild, even if it is after the vaccine. So this is basically a graph showing how common myocarditis is after doses of the BioNTech vaccine. Pretty high risk in adolescents, there's no doubt about it. So young individuals, adolescents, the risk is very high. But once you get to the elderly population, actually it's similar to the population baseline risk. Okay, so I think I'm coming towards the end here, and I think in good time, we still have a few minutes to spare. So because of that, what I'm going to do is I'm going to focus on some of the more recent developments we've had locally in terms of the development of two different antiviral agents, namely a Merck drug by Merck called molnupiravir and a drug by Pfizer that is called Paxlovid. Okay, so we have two new antivirals available in Hong Kong. And I'm sure a lot of the audience is very curious about how this affects the risk of individuals in Hong Kong. Okay, so both of these studies have passed phase 3 clinical trials overseas. And in those phase 3 clinical trials, the patients that were included were mostly unvaccinated. So we are comparing unvaccinated high-risk individuals with Omicron who have received the drugs or who have not received the drugs. And that was the case for both molnupiravir and Paxlovid. Paxlovid, which is the drug produced by Pfizer, is definitely more effective. It reduces the risk of progression to severe disease or death, hospitalization or death by 89%. 89%. Molnupiravir is less effective. It reduces the risk of progression to severe disease and death by 30%. Okay. However, I must say that both seem pretty good in terms of preventing death. You can see molnupiravir is in the molnupiravir group, there was 0 deaths in the trial compared to the placebo group that had 9 deaths. Similar figures for the Paxlovid as well. Okay, 7 deaths in the placebo group versus 0 in the group that was given the drug. Duration of therapy for both is 5 days. They're given twice daily. The important thing to note, very important thing to note, is that both molnupiravir and Paxlovid have to be given as soon as COVID is diagnosed, within the first few days. If you give them later on, when the disease is already severe, say after 1 week, they're not going to work. They're not going to be effective. Antivirals for COVID-19 have to be given early on, within the first week of symptom onset. This is the most important point. So don't think it's okay, I can observe my symptoms, and if I get worse, there are antivirals. It's very important to note that these must be given as early as possible. Molnupiravir, now the thing about Paxlovid specifically is that you have to give it with another drug called ritonavir. Now this drug helps to boost the levels of the Paxlovid in your body. But if you're taking a lot of medications, there is a possibility that ritonavir can interact with these medications in a way that is not too ideal. So doctors do have to go through potential drug-drug interactions before prescribing Paxlovid. Okay, so there are many drug interactions for Paxlovid, but for molnupiravir, it doesn't really matter. If you're taking other drugs, usually not many drug-drug interactions. I just want to note that molnupiravir is an older drug. It was actually made for other viruses and then repurposed for COVID-19, but Paxlovid is very specifically designed for COVID-19, and it's pretty new. So that might perhaps explain why it's more effective, right? It's more purpose-made for COVID. And I won't drill too much into the mechanisms, but they have 2 different mechanisms of action. Molnupiravir induces the virus to undergo a lot of mutations. That sounds like a bad thing, but it actually makes sure that the virus population collapses. Paxlovid is a protease inhibitor, so it prevents the virus from actually completing its replication cycle in the cell. So far, they're both good against Omicron, so that's also important to note. So it's great that we have these antivirals available in Hong Kong at the moment, but the fundamental thing is that we have to give them to patients early on. So the later you give them, the less effective they're going to be. Okay, we're getting towards the end here, and I think in very good time. So that's good. It leaves more time for Q&A. Parkinson's disease, chronic neurological conditions as a group is a high-risk group for severe COVID-19. Parkinson's disease patients are strongly recommended to receive 3 doses of COVID-19 vaccines according to the latest schedule introduced by the Hong Kong government. Both vaccines in Hong Kong are generally very safe. They're not linked to an increased risk of stroke, heart disease, and death. So I think I'm going to stop here. I will stop screen sharing, and I welcome any questions from the floor, and I look forward to an enriching discussion. Thank you very much.
Thank you very much, Sid. That was excellent, eloquent talk. Thank you very much for your very enlightening lecture. Now for the Q&A session. The way that we've done it was because this has really gone to a very, very wide audience, not just only to medical practitioners, but also to informed lay people as well. And that's why we've got this simultaneous Cantonese translation going on. And during registration, in order to make it a bit more efficient, we gathered a number of questions. And I can see some questions here coming on the Q&A chat. And I will try to see whether we can incorporate some of those in our questions which we had received much earlier. We've got 30 over questions that we had received even prior to the webinar. So maybe what we'll do is that we'll just run through those, and I will try to incorporate some of those online questions that we've got along with the questions that we have received much earlier, and see whether we can try to go through it within the time allotted. So let's just start with the questions. Can I get COVID vaccine if I have had a recent stroke within the past month? And along with it, I've got an online question. So a patient who had it for a week ago, 2 weeks prior, having a stroke, can I have the vaccine within that past month if you had a stroke?
Right. So actually, the latest guidance from locally has been that if you have had a major cardiovascular event, like a heart attack, it is actually okay to get the vaccine after 1 month has passed. So once the condition has been stabilized. And I think it's very fair to say that that applies to stroke as well, because we also have to take the COVID-19 context in the community. As I've explained in the talk, COVID-19 actually increases risk of stroke. So getting a vaccine and preventing infection makes sense to prevent that recurrent stroke happening, right? So it would make sense for once your condition is stabilized within a month, if everything is okay, do go and get your vaccine.
That's great. Thank you. I think that suppose that also applies to a number of other conditions. I suspect that that's probably what was mentioned in the Sinovac labeling, saying that if you had, in fact, that brings us to the next question. If I have a history of Guillain-Barré, let's divide it into two populations. One with a history of Guillain-Barré syndrome, but has now recovered completely. Can I get the vaccine if I've had a history of Guillain-Barré, but now I am recovered completely?
Absolutely. So actually, there is data for this for BioNTech from Israel. So they have a cohort of 700 patients with past GBS. And they actually, most of them received the vaccine with absolutely no problems, vast majority. And some had side effects that were not GBS related. So BioNTech, no problem, can go and get it. With CoronaVac, the problem is the product insert specifically says that this is a contraindication, so perhaps best to avoid.
Mm-hmm. my interpretation of the insert, although I'm not sure about this, but I think my interpretation of it, maybe I'm wrong. Maybe the fact that the insert was produced, very early on, and I think in a certain sense of the product, and they were worried about, normal flu vaccines having this sort of a potential side effect, and I suspect that they probably put it in there. But my reading of the issue is that only if you have got a more acute, in other words, a Guillain-Barré syndrome, just like a stroke, happening within the past month or two, and you have not recovered yet from the Guillain-Barré, it would be wise to avoid it. And I think it probably, I'm not sure whether you agree with me, that once you have got Guillain-Barré syndrome that is not due to any vaccination in the past before, and that just came from a natural infection, I think that it is possible to take both vaccines. Would you agree with that?
I actually entirely agree. The recommendation from CoronaVac was not based on actual data showing that there was an increased risk. So if the GBS is completely resolved, it's fair to say that it's probably quite safe. But I would say the problem is more from a medical legal point of view, because that passage is so open to interpretation. So it makes it difficult for doctors to recommend it. So I think it's more from that angle rather than an actual concrete safety concern.
Sure. And I think this also applies to the history of Bell's palsy, isn't it? In the sense that if I've got a history of Bell's palsy before, say from the first vaccine that I've had, has there been an increased risk of Bell's palsy with either vaccine?
Yes, actually, again, great work by the School of Biomedical Sciences, Pharmacology and Pharmacy in Hong Kong U. They found a slightly elevated risk of Bell's palsy with CoronaVac, but not with the BioNTech vaccine. So there is actually that data, but whether a history of Bell's palsy alters that in any way is questionable, is doubtful. But yeah, there is some data saying that CoronaVac might slightly uptick that risk. But I actually don't think that makes it an absolute contraindication, because most of these cases tend to be mild, even if they happen as well. So it's just something to keep in mind.
Sure. I mean, my reading of the issue, I completely agree with your interpretation of that question as well. And my reading of the literature seems to indicate that the patients with Bell's palsy, you can still have these vaccines, because the risk of COVID infection itself far outweighs the risk from Bell's palsy itself, and particularly in the elderly with a lot of comorbidities. And I think that there is, as far as my reading goes, from some of the international literature, apart from the one that the local study did, that was actually performed quite early on, was that that there was no concrete evidence that vaccinations was related to Bell's palsy. I mean, that was my reading of the international. But again, this is a controversial thing that's still going on. Okay, let's move on to the next one. What if I've got a history of autoimmune disease, things like myasthenia gravis or transverse myelitis? Can I get the COVID vaccine?
I think it's fair to get the COVID-19 vaccine as long as the disease is under reasonable control, right? Because catching COVID-19 in these kind of myasthenia gravis is not nice, because if it leads to problems in ventilation, problems in breathing afterwards, then it's very difficult to manage. So I would say that definitely should go and get the COVID-19 vaccine. Which one, again, depends on the interpretation of that problematic statement in the CoronaVac product insert, on whether this actually constitutes one of those contraindicated conditions. But for BioNTech, no, I don't see any contraindication as long as the disease is under reasonable control.
And just to tie in with an online question, should everybody then with a neurological disorder receive BioNTech instead of Sinovac because of the drug insert?
I don't think that's fair to say, because as we were discussing earlier, I think that refers to conditions that are of more autoimmune etiology, like Guillain-Barré syndrome, transverse myelitis. I think that's what the company was concerned about. But if you're talking about things like Alzheimer's disease or Parkinson's disease or previous stroke, then that I don't think that statement reasonably applies, and they can really choose whichever one they're more comfortable with. Also bearing in mind the fact that they are strongly recommended to receive a BioNTech dose anyway, even if they choose CoronaVac for their first 2 doses.
Sure. So there is, I mean, again, I completely agree with that. And I think that there is no evidence to indicate that, that either vaccine can cause neurological autoimmune disease. I suppose some of those cases that came through earlier on, maybe they were the one that you would expect from a background rate. I don't think that there was any concrete evidence to indicate that the vaccinations was increased or was associated with a much more increased risk of a neurological autoimmune disease, again, from my reading of the international literature. Okay. If we can just move on, to the next slide. Let's see, I'm just trying to see whether we've got, no, we'll just move on to the questions, which is here. Can I get the COVID vaccine if I have fever from a non-COVID related chest infection?
The recommendation is to settle the fever first. So actually, I do have patients in hospital who ask me this all the time. And I tell them, look, if you get the vaccine today and you have a fever tomorrow due to the vaccine, I don't know whether it's because the infection is not settled or whether it's due to the vaccine. So it's always advisable to settle your infection first, right? With the course of antibiotics or whatever it is, and then get your vaccine. Also, why I say that is because your immune system is working on something already. It's fighting a bacteria or some other virus. Maybe you don't want to increase the workload at that time. So again, just settle the infection first. You put your body in a good state where you're fit to receive the vaccine and then get it. You don't have to wait for too long. If your fever's down for 2 or 3 days completely and everything else looks good, then sure, can go and get it.
So this would, in a certain sense, is that right to say that this would be consistent with the CDC guideline or CHP guideline to say that if you've got a unstable condition, get through that first before you have the vaccination, which makes sense in a certain sense, isn't it? Whether it be a heart attack or a stroke or a chest infection, which is non-COVID related. What about can I get the COVID vaccine if I've got a mild symptomatic COVID infection, such as a mild fever, mild headache, and sore throat?
Oh, if it's an active COVID-19 infection, then a vaccine is not going to help. Mm-hmm. So I guess this would also apply to question G. So if you're actually having a COVID infection currently, then the Hong Kong government actually says that you would have to wait 3 months to get your first shot of COVID-19 vaccine.
Right.
And that kind of makes sense because if you're infected already, you're going to have some degree of short-term immunity to the virus that lasts for 3 to 6 months. These guidelines are much more aggressive. They say once your symptoms due to COVID subside 2 weeks or so, you should go and get the COVID vaccine. In Hong Kong, the current recommendation is 3 months after the COVID-19 infection.
Can we move on to the next set of slides? Right. So I think this has already been answered. If I'm able to take the vaccination with these disorders, how long should I wait? So it's roughly about 1 to 3 months, isn't it? Is that right?
Yeah.
Okay. Is there any preference between BioNTech or Sinovac for any of these disorders? I think we've sort of more or less covered this issue here. I don't think that there is much in a way of preference between those two in terms of side effects.
Oh yeah, scientifically speaking, no. It's just a matter of the wording in the product insert more than anything. Yeah.
Right, okay. Now, can we move on? So in a patient with myasthenic or epileptic patient with seizures, if titration medication is present, is it stable to give the vaccine? Sorry, I think quite understand this question. If titration medication, so I suspect that probably is asking if I've got myasthenia, which we have already answered, that you can have it. Not in active myasthenia, but somebody with a history of myasthenia gravis, you can have it if it is stabilized. In somebody with a stable seizure, can you give the vaccine in epilepsy?
Oh yes, if the epilepsy is stable, and the titration is not because the seizure frequency is very high, then I think it's fine. I think I think Professor Ho would be in a much better position to answer. But generally, I feel like if you get a vaccine and say you get BioNTech and you get a high fever the next day, I don't know if that increases the risk of breakthrough seizure. That's the answer. But if your epilepsy is stable and you're actually titrating down because your epilepsy is stable, then it's absolutely fine.
Sure. Yeah, I completely agree. I think it applies to anything that's in general. So if somebody has got an unstable condition, because the vaccination, remember, is not a treatment, it is to prevent COVID rather than to treat COVID. I think it would be wise to let the unstable condition settle, whatever the condition is, to settle into a stable condition first before considering vaccinations. Which brings us to the next one, which is patients with ADEM, acute demyelinating encephalomyelitis. Can we get the COVID vaccine? I suppose that is also the same sort of answer with myasthenia and other autoimmune diseases, right?
Yes. Yes.
Right. Okay. Now, this question here says undiagnosed neurological disorder with unstable. Is it safe for me to receive vaccination? I suspect that this question is a bit too difficult to answer because, in a certain sense, it is undiagnosed. I'm not quite certain what it is. But in general, if a condition is unstable, it is better to let it stabilize first for whatever it is. Before receiving a vaccine. Am I right, Sid?
Yeah. I think it would have to be case by case. So this question perhaps is a little non-specific. So I think it would depend on how unstable is, right? The specifics.
Right. Okay, can we move on to the next slide? Any side effects for Parkinson's disease patients regarding, I suspect that it means regarding COVID vaccine. I think you've more or less answered that question. For patients with Parkinson's disease, if they receive COVID vaccination, they might receive maybe some discomfort or fever or myalgia. I suspect that if they have any of these side effects from the vaccination, any of these would actually temporarily worsen Parkinson's disease control, not because of vaccination, but because of just the general fact that if somebody has a fever or somebody who's feeling unwell from other things unrelated to Parkinson's disease, it will worsen Parkinson's disease. Would you agree with that, Sid?
Sure. I think I quoted a study in my talk. So out of 177 people who received the BioNTech vaccine with Parkinson's disease, only 2 had a very transient increase in tremor or stiffness, and it quickly improved. And I think that's not related to the vaccine. It's more due to the fever and the kind of discomfort that they feel after the vaccination that may trigger that kind of temporary kind of worsening. But they quickly went back to normal. So I'm not concerned. I think the benefit is far more than the risk.
Sure, absolutely. Yeah, I've got a number of patients with Parkinson's disease who've contracted COVID. Some of them symptomatic, some of them came back RET positive. They recover quite well. And which brings us on to the next question, where the patient had the vaccine, then was infected with COVID before receiving the second dose of the vaccine. Will it cause a reversible effect on the Parkinson's disease? My answer would be no. Would I be right?
Yes, I think if you have received one dose of CoronaVac, it's not going to make much difference to the symptoms of COVID-19 per se. So you may experience some transient deterioration in motor and non-motor functioning, but it should get better by itself. So it's not going to permanently change the natural history of your Parkinson's disease.
Right, I completely agree. Okay, thank you. Oscar, can we move on to the next question? And this rather personal question saying that my relative was diagnosed with Guillain-Barré twice, each time hospitalized for several months. During that time, we consulted doctor's opinion on vaccination. The answer was presumably he didn't get a suitable answer according to the patient. And then they consulted the doctor again that the comments was too suitable for vaccination this time, and they got confused. Any thoughts on that? My own feeling is that, well, Guillain-Barré syndrome itself it's unusual because it tends to be a monophasic disease rather than a multiphasic disorder with recurrence. It's very unusual, but if they have got Guillain-Barré before and is now stable, my reading of the literature is that they can have the vaccination. Again, it really depends on the nature of the Guillain-Barré. If it is unstable, like in all unstable conditions, whether it be Guillain-Barré or any other neurological disorder, it is best to postpone or delay that vaccination until the condition is stabilized. And I think that would be reasonable. Would you agree with that?
Yeah, if you had Guillain-Barré in the past and the symptoms and it's completely resolved now, yes, you can get vaccinated because COVID-19 is very severe in the community now, and benefit of vaccine is much higher than risk. So please go and get it. But you have to let people know your history because that's going to affect the type of vaccine they give you. I think with the specific history of GBS, they might be more inclined to give you BioNTech.
Okay. And then can we move on? This was a personal question again for somebody with Parkinson's disease. Now the patient has got pemphigus as well, the skin condition, autoimmune skin condition, and takes antibiotics. Would they be suitable to receive a COVID vaccine?
They must receive a COVID vaccine. At 92, if you have underlying Parkinson's as well as pemphigus, I've shown the death rates in Hong Kong are nearly 12%. So it's honestly a situation where vaccines are absolutely required to bring down the death rate. So I think we should not hesitate.
Yes. I've had a patient again with, I'm not sure, I think it was a different patient with Parkinson's disease, but also, strangely enough, had pemphigus, but was taking immunosuppressants, MMF, and steroids. And the advice really would be to get the vaccination as soon as possible once stabilized, because the thing is that the patient, if they are on immunosuppressants, makes it even more important for them to receive the vaccine. Is that right?
Absolutely.
Great. Okay. So can we move on to the next question about any measures? Hang on, where was this? Any measures by the government in taking care of patients? I think this is a very, very general question for the thing. I think the government, my understanding is that certainly from the daily news briefings and the news conferences and the advertisements and the various government officials and civil servants coming out to give the talk, I think on COVID-19 there has been a lot of information given to the public. As far as for Parkinson's disease concern, I'm not sure whether there have been anything on specific that relates specifically to PD patients, except to say one thing, that PD patients, Parkinson's disease patients, being in an elderly population, it would actually fit into this category where we equate Parkinson's disease patients with the elderly, not specifically to COVID, but to elderly patients. And I think that for PD patients, particularly the elderly ones, should really have the vaccination. Would you agree?
Yeah, no doubt.
Okay, so let's move on. again, a very long case where it's a patient with Parkinson's disease with unstable blood pressure and had received flu vaccination, but then developed various features of myalgia, fever, but not actual neurological deficits. And the patient is not comfortable to receive the vaccination. And so the patient is unsure whether they should receive the vaccination, but is very, very reluctant. And the patient is afraid of getting a stroke after the vaccination because of unstable blood pressure. And so basically, and it is a very, very common question that we get from Parkinson's disease patients and patients who are elderly, who are very reluctant. What message would you give to such patients, Sid?
I think I'm going to focus on one particular sentence here, which is, I'm afraid of stroke after vaccination. And I really hope that I address that directly in my talk, that there was absolutely no evidence on a population-wide basis that vaccines raise stroke risk. So we've had very high quality studies that show that this is not the case. So if that is your specific concern, then I can say that these vaccines would not alter your risk of having a stroke compared to if you hadn't received the vaccine. On the other hand, if you catch COVID-19, there is absolutely no doubt that you are at increased stroke risk in the 1 year after COVID-19 infection. So again, benefit versus risk, as well as the vaccine pass issues and the inconveniences that you're facing. I really hope this talk can kind of adjust your risk-benefit analysis a little bit when you're considering the COVID-19 vaccines.
Sure. Just reading from the history of what the patient gave, it looks as if the patient probably does have some degree of autonomic dysfunction, because after taking the PD medications, presumably the patient then developed hypotensive episodes, and that's why they get dizzy from the medication. And I think in such cases, it is best to actually deal with the blood pressure issue as well as getting the vaccination. Would that sound reasonable, Sid?
Very fair. If it's an unstable medical condition, then just sort out that issue first, and then.
Sure. Okay, can we move on? We've got a lot of questions. So unfortunately, this one is diagnosed with COVID-19 and feeling exhausted, can't stand up. Well, I think that this is something that is not uncommon to get this sort of symptoms. That's why it's so important to get the vaccination done as soon as possible. And I think, what sort of advice can be given to this to his wife with Parkinson's disease?
Yeah, it's not uncommon, because if you have underlying Parkinson's disease and get an infection like COVID-19, then it does affect the motor symptoms to a certain extent. The most important thing is, it's already on the 5th of March, already past 2 weeks. The most important thing is that it should gradually improve. So just keep an eye on things and do consult your doctor if required, if the Parkinson's disease is out of control.
Okay, I just want to interrupt slightly. We've got a lot of questions coming on Q&A. I will try to attempt to answer those questions after we finish these pre-existing questions first. I'm a relative of permanent. So again, it's a sort of similar sort of thing. I think you've already answered that. Is there any permanent damage caused to PD symptoms? My answer would be no, not directly from the PD patient's symptoms itself. And I think if they recover from the COVID, there is a very high chance that they should get a recovery back to their previous baseline before they had COVID. Would you agree?
Yes.
Okay. Can we move on to the next one? And I'm sorry that these are sort of treatment that is not quite related from neuralgia and keep shaking. For Parkinson's disease patients, those are treatment related rather than related to Parkinson's disease rather than COVID patients, rather than specific COVID treatment. Can we move on? So this was the case about a thing where a patient suffers from epilepsy. Can I get the shot if you are stable and if your epilepsy and convulsions are under control? There is no reason why you cannot get the COVID vaccination. And so in somebody with, whether they've got serious epilepsy, as long as their convulsions are under control, there's absolutely no reason why they should not be able to get their COVID vaccine. Would I be right?
Sure.
Yeah. What about the risk of transverse myelitis on vaccination? Sorry.
I was just about to say no signal that they increase risk for BioNTech. For CoronaVac, also probably not. I haven't heard any such safety signal anywhere in the world.
Sure. Okay, let's move on. So, vaccination after getting COVID, can you perhaps sort of enlighten us a bit more about this? If I've got COVID-19 recently, can I get the vaccination after that? I think it's within a month. Is that right? Or 3 months?
3 months.
3 months. Yeah, 3 months. So after you get COVID vaccine, whether it's symptomatic or non-symptomatic, you can get the vaccine 3 months after, right? Okay. And the patients with herpes zoster after COVID-19 infection, do you have any data relating to this effect?
Not specifically, but it's not uncommon. If you get, above the age of 50, if you have any kind of acute stress due to an infection, it can certainly predispose to herpes zoster. So they are related, but I don't have specific data relating to this matter on how common it is, but not uncommon, I'm sure.
Yeah. And I just maybe would like to add that with people with herpes zoster, if you've got recurrence of shingles or herpes zoster infection, it's possible that you have a very temporary bout of immunosuppression at some point. That's why you get a recurrence. And I suspect that that's probably what happened, not because of the COVID infection, but maybe was due to something else that came on that triggered off your herpes zoster. How will inactivated vaccine or mRNA vaccine affect anxiety disorder, respectively?
No evidence that they affect anxiety disorder in any way, so I wouldn't worry too much about it.
Sure.
Unless they cause stress when you of side effects, or if you're psychologically, if you're worried about them. But
in fact, just maybe a message to reassure those patients with anxiety disorder. The fact that you have anxiety disorder would also make you think about the consequences of getting COVID infection, rather than worrying about the side effects or potential side effects from the vaccination. I think that message would be more appropriate. Is that right, Sid?
Sure.
Yeah.
Yes.
Okay. So maybe we will just move on to the last set of questions. What are the after effects of mild or COVID or severe COVID infection, respectively? So what are the long-term side effects? I suspect that's probably what the question is about for mild or severe, mild and severe. So two different groups.
Yeah. So irrespective of severity, about 10 to 20% of all COVID patients get something called long COVID. So it's basically persistence of respiratory symptoms, fatigue, difficulty in concentrating, and this can last for many months. And this is what we call long COVID. Now, the good thing about this is that even long COVID rates are reduced if the infected patients were vaccinated before. So actually vaccination can reduce risks of long COVID. Now with severe COVID-19 patients, there are a lot of problems that happen downstream, including respiratory issues in patients who have recovered, but also, as I repeatedly mentioned during the talk, it was the risk of heart disease and stroke that actually goes up quite substantially in the 1 year after recovery from severe COVID as well. So these will be some of the after effects.
And okay, I think if I'm not mistaken, I think there was a paper published in Nature recently talking about some degree of long-term effects on the brain. But this is only based on neuroimaging, studies in various parts of the brain, even with mild COVID infection. But how much of that is translated into symptomatic, I think it's a bit difficult to say, or too early to say. Is that right, Kobe?
Yeah, but that's a very controversial study. A lot of people disagree about what the actual consequences of those neuroradiological abnormalities were. So very interesting. But actually, there is some evidence to show that even something like influenza can cause a lot of neuroradiological changes in the short term. So it remains to be seen how significant that is. But long COVID is a real entity. And it scares me how much long COVID we are going to be seeing in Hong Kong in the next few months.
Right. This is again a personal question where a patient had 2 doses of Sinovac vaccine. Should they receive a Sinovac or BioNTech for the 3rd dose?
BioNTech.
Yeah, or BioNTech or Sinovac. And the patient claims that says that he's weak and thin, presumably easier to get affected by, various previous vaccines, and had received 2 doses of vaccination. Should they receive Sinovac or BioNTech? Is this a personal choice, or is that much to encourage one or the other?
It is a personal choice to a certain extent, but I will say this: there is a misconception that BioNTech is produces more severe side effects in the older population.
Right.
Actually, that hasn't been my direct experience. Now, when I got the BioNTech shot, I've gotten 3 doses. It's been quite difficult for me the next day. I really have to take a day off work, get a low-grade fever, and generally feel very fatigued. But older people who receive BioNTech, they tend to have milder reactions in terms of fever and fatigue. It doesn't tend to be that serious as younger individuals. It's because of a weaker innate immune response, and how they respond to the BioNTech vaccine doesn't tend to be that bad, to be honest. So if the person asking question 23 is worried because if they fall into an older category, there is a chance that their BioNTech vaccine would not cause a lot or as much side effects as they think.
Sure.
Yeah, but the official recommendation at the moment is strongly recommend BioNTech for your third dose, because that really boosts those CoronaVac antibodies better than a CoronaVac 3rd dose. But it's a personal choice at the end of the day.
Maybe if I can just twist the question round, I'm weak and thin and easy to be affected. I received 2 doses of BioNTech vaccine. Should I receive the Sinovac for my 3rd dose?
Receive BioNTech for your 3rd dose would be better. Receiving an inactivated vaccine after 2 doses of mRNA vaccines is not is slightly suboptimal, actually, which we have shown for another inactivated vaccine called Sinopharm from China as well. So we know that for that vaccine, getting a 3rd dose inactivated after 2 doses of mRNA is not ideal. So what if
the patient had, say, a history of myocarditis, which is unusual in this population of elderly? But if somebody was a bit younger and had a bad reaction after the 2nd dose of, say, BioNTech, would you recommend having a 3rd dose as Sinovac?
Absolutely. No, it depends. If they have a BioNTech vaccine-induced myocarditis after their 2nd dose, then that's it. Don't get the BioNTech vaccine again. It depends. If they're younger individuals, actually, I would say forget the 3rd dose, because it's you're not that likely to die anyway. But if they just have a history of myocarditis in the past, actually, I had a patient with fulminant myocarditis who required a heart transplant who asked me the same question: which vaccine should I get? My recommendation to her was to get the CoronaVac vaccine, but I will point out that the CDC, the US CDC, is actually very aggressive. They say if it's not myocarditis related to BioNTech, you can still get BioNTech without definite contraindication, which is
Right.
reasonable because the person who asked me that was middle-aged female, and they don't tend to get BioNTech vaccine-related myocarditis at all.
Right.
So it's it depends. Yeah.
Right. Okay. So I'm not quite certain here. Vaccine-induced S protein deposit in brain result. I can't quite understand this question though.
Oh, I understand it perfectly. This is very, very common. A narrative spread by some anti-vaccine groups that the S protein that is produced by mRNA vaccines actually triggers inflammation in different parts of the body. I just want to say there is absolutely no evidence that this happens. The S protein, spike protein expression is actually transient, temporary. It fades away within a few days. So don't worry about it. It's sticking on in your body and causing an inflammation here and there. It just doesn't happen. And we have millions and millions and millions of people vaccinated with this vaccine in the last 1 year, right? 1 year and 3 months. And the safety signals have been amazing.
Sure. Okay, can we move on? Are there any more further questions there? The long-term sequelae of natural COVID infection versus vaccinations. I suspect that he's trying to, find out what are the long-term consequences of a natural vaccine versus the risk of vaccinations. I'm not quite certain whether I'm interpreting it correctly. I'm not sure whether the question is trying to say that if I were to get Omicron as a natural form of vaccination, would that be a better bet than getting the vaccine?
Yeah. Hey, the proof is here. So we've had COVID-19 for 2 years. We've had vaccines for 1 year and 3 months, so pretty similar. We've had billions of vaccine doses administered, worldwide. We've also had 1 billion or so infections. To date, we know that there are long-term consequences of infections, long COVID, heart attacks, strokes. Getting COVID-19 infection is no joke. Safety signal of vaccines in the long term, we're already talking about a 1 year of follow-up, has been fantastic. So I think it's very, very unlikely that we're going to see some bizarre side effect come up 5 years or 10 years after a single dose of a COVID-19 vaccine in 2021. So it's obvious, honestly. Getting immunity from vaccination is far safer than getting immunity from a natural infection.
Yeah. Just a question online, since we are on this thing on side effects. It says here, showing the, can you please show the myocarditis rate against the age again? Though all the cases are mild, all cases of myocarditis is mild, are there any long-term side effects from myocarditis in these sort of patients? Do we have data on that?
Actually, I did show the data on the graph. The rates of myocarditis are fairly high in after BioNTech in young males. So we're talking about adolescents and people in their 20s. But once you get older, the risk is more or less similar to baseline. So you don't have to worry too much about myocarditis after the age of 25 to 30. After that, it really starts dropping very quickly. Most of these myocarditis cases were mild. Okay, so they came into hospital, a little bit of chest pain, treated conservatively, and they could leave. So there's really no evidence that they suffered a loss of exercise tolerance or things like that after their myocarditis healed. So there weren't a lot of long-term side effects. But it does make one think about the risk-benefit analysis for COVID-19 vaccines, mRNA vaccines in younger individuals, especially if the COVID-19 situation is not too severe. So that's an ongoing discussion we're having. Especially the UK tends to take a very conservative approach to COVID-19 vaccination in adolescents because of this myocarditis issue. But for older adults, not a concern, really.
What advice would you, I'm just following on, what advice would you give to these patients who had myocarditis, say from a vaccine, in younger patients? I know that this is, we are talking about older patients, but in younger patients, can they exercise?
Right. My general recommendation is anyone after receiving BioNTech should not exercise for a period of 1 to 2 weeks. Don't do any strenuous activity, just lie down. So even if you have, the thing is, even if you have a little bit of myocarditis cooking up, exertion might trigger an arrhythmia if there is myocarditis. So for that reason, it's perhaps better to just take it easy. But after that time, after 2 weeks or so, like for me, I'm fairly physically active. I resume exercise 2 weeks afterwards, but build up gradually afterwards as well.
Sure. Okay, can we move on? Are there any further questions? I think we have got this thing. Is it okay to receive BioNTech as a third vaccine? I think we already answered that, and that is the thing that you've already said. In fact, there was one of the recommendation to have the BioNTech as a third vaccine dose after 2 doses of Sinovac. Yeah. Any data on the vaccine history, including type number of vaccines for severe death COVID cases in Hong Kong? Most elderly have fixed idea that BioNTech have got more adverse effects than Sinovac. Are there any data on allergy adverse effects on BioNTech and Sinovac in Hong Kong?
Yeah, it's all out. I think I showed it in my graph. We know that people who have received the 90% of the deaths were in people who received less than 2 doses of a COVID-19 vaccine. The government has not released data on which vaccine they received, whether BioNTech or Sinovac or CoronaVac. For this, I think it's better to do a little bit more analysis on it before releasing that study. Allergy and adverse effect rate in Hong Kong, I also shared the data on the study from the pharmacology and pharmacy colleagues, and I think it's very, very favorable for vaccines.
Good, thank you. And can we move on? There have been reports of blood clots, myocarditis. Let's just deal with blood clots first. Now, I understand that at least one of the concerns, I think if I remember correctly, I think it was AstraZeneca, which is not done in Hong Kong, was related to some venous thrombosis due to some effects on platelets who received the AstraZeneca vaccine. And I think some countries, if I remember correctly, stopped the AstraZeneca vaccine from that, although I think there was some debate following the stoppage of AstraZeneca in some European countries. What comments would you like to make on that?
So yeah, again, the same pharmacovigilance safety monitoring mechanism picked up blood clots occurring due to AstraZeneca's vaccine very early on. And once that happened, there were some parts of the world that decided to restrict that vaccine for younger adults, especially women. Having said that, it's actually my entire family overseas has received the AstraZeneca vaccine, and I have had absolutely no problems recommending it to them. It's very safe and effective in general, and that complication is very rare. Now, for blood clots due to BioNTech, absolutely no signal that this happened. So the same mechanism that already told us about the AstraZeneca issue is indicating that the BioNTech vaccine is very safe with regards to blood clots, as well as heart disease, heart attacks, and strokes, which is also asked in this question.
Sure. Okay, can we move on? I think we have already mentioned quite a lot whether you should choose. I think it's very much a personal choice. And I think that Dr. Siddharth has already covered quite a lot on trying to weigh up between BioNTech and Sinovac vaccines. Maybe we come to safety in babies. Have there been any data for safety in babies on either
children up? By babies, I assume it's less than 1 year of age. Generally speaking, for neither vaccine is indicated for this age group at the moment. We don't have enough data to recommend it either way.
But I understand that Sinovac can be given up down to 3 years old. Is that right?
That's right. After the age of 3, you can give CoronaVac, Sinovac.
Yeah, Sinovac. Can we move on? What kind of exercise most beneficial for new onset COVID patients? What would you recommend?
Don't exercise. Just take rest.
To new onset. So in other words, somebody who's symptomatic, take a rest.
I assume the person asking this is younger.
Yes.
In that, do remember that COVID-19 also has a myocarditis risk. And
Right.
it's well reported in young athletes, that COVID-19 infections can themselves cause myocarditis. Don't exercise, just rest. Let your body relax a little bit. You need the energy to fight off the infection.
Sure, for maybe 1 or 2 weeks until to recover.
Sure. Even after you recover, it depends on how the long COVID symptoms are. Take your time.
Right, and I suppose these patients who with newly onset who are still RAT positive should not be going out in the first place, right?
Should not, or even at home if you have a home gym.
Yes, to be on home isolation, unless they're symptomatic, of course. I'm a new onset COVID patient, 56-year-old. What exercise is recommended for me? What would you say?
It's just rest.
Rest, yes, okay. And I think the last question from the pre-existing patients, any new patients, new drugs affecting medicine. So,
okay.
So those were the two questions. Those were the two drugs that you mentioned in your last slide, I think.
Right. I think new medicines I did mention in the last slide. How they affect Parkinson's disease, it really depends. You have to get out the drug list and really check whether Paxlovid has an interaction with specific drugs that are given for treating Parkinson's disease. Sure. It's a very long list, and I'm sure I'd miss a few if I rattle them off now. So you've got to go through for drug-drug interactions very carefully. Molnupiravir, the less effective one, is less of an issue with drug-drug interactions. I think that should be fairly safe.
Sure. Yes, certainly my reading of the data so far now is that the molnupiravir, or the one that is sent out by Merck, is quite safe for patients with Parkinson's disease. For the one by Pfizer, the later one, Poverex, Poverelid, is it right? It can interact with drugs that are metabolized by the liver. If you've got patients who have got liver failure or kidney failure, or have got impaired kidney function, you have to consult your doctors before you. Besides, the doctor would need to look at those drug interactions first before giving it to you. And certainly, if you've got kidney impairment or liver impairment, certainly go through it with your doctors, because I think that is the thing that you need to be aware of, because there are interaction with certain drugs. And I think you did briefly mention it in the last slide. Yeah. Okay, now let's try to quickly cover some of the online questions here. I think most of them we already covered. I'm just trying to see what is the secondary attack rate?
So I assume this means household secondary attack rates. Overseas, it ranges from 10 to 40% for all.
10 to 40.
But in Hong Kong, that would be much higher because we have much smaller houses. So I'm sure it's more than 50%. Actually, likely much closer to 80 to 100%. Most families that I know who have caught COVID, all of them catch it together, I'm afraid. So
it's highly
infectious. Unmanageable, really.
Right. Another question says, my mom has got 2 vaccines. She got COVID before getting her 3rd vaccine. I canceled her appointment, waited for 3 months before she gets a 3rd vaccine. Is that correct? She's now negative of COVID.
That's right. So you have to wait for that. So I think the government has put out some posters on this. So please refer back, because this does keep changing. So please refer back to the CHP coronavirus vaccine for the latest information.
Sure. The question says that will Sinovac increase the rate of cardiovascular events such as ischemic heart disease and strokes transiently within the 1st or 2nd weeks? I think the answer is no, right?
No signal that happens. Okay, so and this is from the pharmacology and pharmacy study that I presented in the talk. This doesn't seem to happen on a consistent population-wide basis.
Right. Can I just mention it to Dr. Yeung and Dr. Lorinda Kwan? If you are trying to look for where the online questions are, you can press onto the Q&A question section, and then you can see some of the questions there for your interpretation. That would be of help. So the next question is, I'm a fully vaccinated PD patient, but I'm interested to know if an inactivated virus injected into the human body would cause any harm. Does that imply that any other vaccine might or may not? I'm not sure whether you can see the question there.
I can see it. No,
Yeah.
that doesn't imply that other platforms are safe or harmful. I'm just saying inactivated vaccines are killed vaccines. So once you inject into them, it's an inert substance that doesn't infect you. The same applies to mRNA vaccines. They are an inert substance that doesn't infect you. So actually, it's the same for both. Right.
Now, can you read the 3 questions in Chinese, Sid, if you can?
Which one is that? Okay.
Yeah.
The ones that are next.
Yes. Would you like to answer those?
Yes, I assume the first one is talking about schizophrenia risk.
Yes.
No concern. So,
yeah, no, that's fine. Yeah.
The next one is talking about replacing vaccination with with the antivirals, with the molnupiravir. No, it's not a substitute, because when you get vaccinated, you get protected from within, okay? And it's a very durable protection that lasts for a long time. The problem with these kind of antivirals is, okay, if you get them, first of all, the antivirals are much less effective than the vaccine, because the vaccine protection is 80 to 90%, but the molnupiravir is only 30% effective. So it's not as good. And also, it's not a long-term durable protection that is built into your body, right? So you may escape one attack, but what if Omicron continues in Hong Kong for the near future, or another variant comes up? Then you still need vaccination to protect yourself.
Right. Am I right to say that if you've had, say, for example, the Delta variant, can you get enough immunity from the Delta variant infection, previous Delta infection, to save you from an Omicron infection?
No. So infection from previous variants would not protect you against an Omicron infection, although it may reduce severity of disease somewhat.
Okay, so I think that's quite clear there. So in other words, the thing is that do not take risk and try to get the endogenous vaccine by getting an infection instead. So can you just move on to the next one?
Yeah, the next one is basically talking about a 3rd dose of CoronaVac after 2 doses of CoronaVac. Not as good as 3rd dose of BioNTech. Okay, so you would be more likely to get infected. There's no doubt. If you get 3 doses of CoronaVac instead of 2 doses CoronaVac plus 1 dose BioNTech.
Talking about treating yourself whilst living at home, unfortunately, this is something that the government has to address. Have you been aware of what things can these patients do when they're living alone?
Most important,
very tough.
If you have milder symptoms, but if you have risk factors for severe COVID, then it's important to get to a designated clinic and try to get those antivirals. Those really make a difference, especially if you're unvaccinated. That's very important. Okay.
Yeah, that's a very, very good suggestion. What about 2 myelitis case deemed to be due to BioNTech? Would you like to comment on those?
So cases, I'm not aware specifically whether this is referring to cases in Hong Kong or overseas. I don't know which incident this is particularly relevant to. The problem is when you have cases occurring after vaccine, the human brain is like, it's because of the vaccine. But the reality is that we always have a baseline risk of these rare medical events happening. When you're giving millions and millions and millions of people vaccines, it's always likely that some of them may come up with these kind of nasty adverse events, but it may not be related to the vaccine. It may be purely coincidental. What I can tell you is on a population-wide basis, there is no evidence that BioNTech increases your risk of myelitis compared to an unvaccinated individual. We have very powerful safety signals, especially safety systems, monitoring systems, especially for BioNTech.
Mm-hmm. And the Parkinson's disease patients are at a public hospital. You can take a jab, and the patients say, "Don't take Sinovac; it will affect the brain." Is that the case?
No, it won't. Don't worry. Don't worry. You can get it.
And for those patients who are undergoing a deep brain stimulation, is it safe to take the vaccine? My answer would be yes. It's completely safe. Yeah. And another question here. I had my first vaccine in January, presumably this year. After 3 weeks, my maid had been classified as positive in the test result. Since I've attended my second vaccination, I was told I was infected with Omicron. Later 1 week, I had recovered and self-tested negative after 14 days. When should I take my second vaccination?
Yeah, I believe it's now delayed to 3 months after the infection, according to the latest government guidance. So it also depends a lot upon your underlying risk group and immune condition. So actually, they have uploaded some useful information on the CHP coronavirus website.
Right.
So please do refer to that.
Right. And the same patient mentioned that the patient's involuntary movement is more frequent after getting infected with Omicron. That's not unusual because with any concomitant illnesses, whether it be flu or other infections or a urinary tract infection or chest infection or even after surgery, their control of Parkinson's disease tend to be a bit worse temporarily. And that's not unusual. What are the long-term and short-term effects if I get COVID?
I think we covered that.
Yeah, sure.
Yeah, so short-term may cause some deterioration of symptoms. Long-term is, of course, long COVID and respiratory symptoms.
Yeah. What is your recommendation for patients with GBS or transverse myelitis due to the first dose of COVID vaccine? Can they receive the second and third doses?
It depends. Generally speaking, if you have, say, you have had CoronaVac and that happens, then you should consider an alternative platform like BioNTech.
Okay.
If it unfortunately happens due to BioNTech, then you may have to complete a course of CoronaVac, but it's on a case-by-case basis.
Sure. So it's very much on a case-to-case basis. Yeah. And just to reiterate, there is no concrete evidence that Guillain-Barré or transverse myelitis is due to the vaccinations from either vaccine. Is that correct? There's no concrete evidence. Yeah. And if it does happen from the first dose, it is possible that it could have been one of the baseline, infections that you had that is in the community. That were you unfortunate that you developed it during the time after you had received the first COVID vaccine? Yes. But maybe you're right in the sense. You're right in the sense that maybe it's worthwhile to consider having a different platform.
Sure.
You've got either one, isn't it? But nevertheless, you should still get the vaccination.
Oh, sure.
Okay. And then moving on, I think we're almost to the end. Would you like to just run through that, Sid?
I believe this is more of a comment.
Comment where?
It's about minor side effects that can happen after CoronaVac. It can happen in the second or third day after receiving the vaccine that you feel these kind of side effects. So it's nothing to be alarmed about.
Mm-hmm.
So don't worry about it.
Okay. And then talking about the elderly patient, grandmother of 96-year-old suffered from ischemic stroke, had diagnosed Alzheimer's and diabetes with regular medication, underwent angioplasty with artificial pacemaker. Is it suitable for her to get vaccination?
If the condition is stable, I think you should strongly consider vaccination because the risk of death with COVID-19 infection at this age is very high. Mm-hmm. Please get 3 doses. And side effects, I think we have covered quite extensively. We're mostly talking about minor local side effects.
Mm-hmm. And including the fact that she's got diabetes makes it even more important, isn't it?
Right.
Yeah. Just as an extension of this, she asked whether it's BioNTech or CoronaVac. Either one will do, right?
That's right.
And if in such a case, say somebody with elderly with a lot of comorbidities, there was some talk about whether they should get 3 doses or 4 doses. Is that something that's still ongoing?
It's only immunocompromised patients who would require 4 doses at the moment. So other individuals are not required to receive 4 doses.
Right. So the patient asked, had 1 dose of vaccine, got COVID, need to wait 3 months for BioNTech, 6 months for Sinovac. Is that right?
I'm not actually sure whether it's 6 months for Sinovac. This keeps changing. They had a recent update. So the most recent information, please go to the coronavirus vaccine website, COVID-19 vaccine website.
Website, yeah. Okay. And the infection. So patient had Parkinson's disease for 10 years, and the control got worse after Omicron. Well, even after I recover. So the answer should simply be yes, they should recover, isn't it? Really, I think this should not really have much in the way.
That's right.
So I think we've already covered some of those. Can somebody who had BA1 get BA2?
Great question. Actually, the infection is probably, the immunity is probably cross-protective because BA1 and BA2 are very close to each other. But remember that the protection is likely to be short-lasting. So 6 months down the line, once the antibodies wane down, somebody with BA1 can still get BA2. In Hong Kong, the more important question is if somebody gets BA2, which is what's going on at the moment, can they get BA1? Answer is down the line, eventually, yes, they would become re-susceptible.
And the last question, hang on, there are 2 more questions. Does intravenous immunoglobulin treatment for autoimmune affect so can something like IVIG for autoimmune neuropathy affect the effectiveness of COVID vaccine?
It might, depending on whether the IVIG products actually contain a lot of antibodies against the vaccine, but it shouldn't have too much of an effect. Actually, if I'm not mistaken, there is some guidance saying on how to space out immunoglobulin products and COVID-19 vaccines. But when you have a lot of active COVID in the community, it may still make sense to get the vaccine, even if you're receiving immunoglobulin treatment.
Right. So I think this was the last question here. Can I get the second vaccination after I recover from Omicron in February? Yes, isn't it?
3 months, yeah.
Yeah, 3 months. Should I take the BioNTech? Yes. Okay. Well, I think we've covered a very, very large number of questions. And first of all, I'd like to thank Dr. Siddharth for his patience and for his eloquent talk and for his expertise on this topic. This webinar has been recorded and will be put on the Hong Kong Parkinson's Disease website if you are interested to go on it. And I would sincerely like to thank Dr. Siddharth for taking all this time to give us this talk, and I'm very grateful for that on behalf of all the patients and all the healthcare professionals that have benefited from this webinar. I would also like to repeat my gratitude to Lundbeck, our sponsor for this webinar. And I also like to thank our 2 interpreters who have this very difficult job of interpreting our rather fast-paced talk. Dr. Young and Dr. Larenda Kwan Chen. And I also, last but not least, I also like to thank our Secretariat, Oscar, Amber, and Vinci, who organized this whole webinar for us, and I'd like to thank them as well. So if there are further questions, maybe you could consider sending them to things, but we'll try to see what we can do to answer them. But unfortunately, we can only have so much time. We've already gone way past the time that have been allocated for this webinar. And I'd like to thank all of you for attending this webinar and have a very good afternoon. Thank you very much. Bye-bye. Oh, just to for the healthcare professionals, please do do the CNA accreditation evaluation form. And for those non-healthcare professionals, please do have that evaluation form to give us some feedback on how useful you found this webinar. Thank you very much. Thanks, Sid. Bye-bye. Bye. Okay,
Thank
you
you.
can leave now.
多謝，唔該晒。4位，
Thank you.
我哋影個合照好嘛？我哋
好啊。
Dr. Siddharth. I think he just left. No problem. We will just still take a group photo.